Well, welcome to the show, Dr. Jain.
Call me Rakesh, and I'm very happy to be with you. Thank you for the warm welcome.
Wonderful to have you. I've been looking forward to this conversation for a long time and following your work for quite a while. For those of our audience who are not familiar with your work, we're really excited to have one of the world's experts in psychopharmacology, someone who's done a lot of research on psychopharm, and thank you for your contributions. It's so important, the research.
Thank you. Thank you.
Yeah. And I'm wondering if we could start the conversation with you giving us an overview of how you see the role of medications in present-day psychiatry as we know it at the moment.
I'd be happy to talk about it. So I do think when you say medications, I suppose you mean psychopharmacology. And I do think psychopharmacology does have its very definitive role in helping fellow human beings who suffer from various mental health challenges. Life can be very challenging, right? The slings and arrows, as Shakespeare said, can be quite profound. It can be very helpful, though, of course, there is a great worry by many of us, including those of us who spend almost an entire career trying to develop new medications, that there may be potentially an overuse of them, both in terms of frequency as well as duration. But I do want to hasten to add at the very outset, there are very many people, very many, and some of them are actually my own family members, who have been on medications for over 25 years, psychiatric medications, and they are only in their 50s. And I expect that they will live their entire lives with their medication. So they most likely would spend 50 to 70 years, if they're so lucky to live that long, with medications on board. So it's a complex topic. It is not as simple as saying it is overdone, it is underdone. I think there are situations it's overdone, and there are situations where it's underdone.
Thank you. Yeah. That seems like a great place to start.
Yeah, I think that's a good segue into maybe just seeing how your own personal treatment philosophy has evolved over time. And how you relate to medications, say how you're relating to them decades ago versus now. Has anything changed there for you?
Great question. And the answer is yes. And if you ask me tomorrow, I will say it's evolved even further. So there's a daily evolution I believe everybody should have. It's a bit like driving. Even if you're driving on a straight and narrow road, you still have to make minor corrections in both directions. I do catch myself. I really do. On occasion, delaying medications too long. And on some occasions, overdoing medications too long. But I do want to address your question quite directly. How have I evolved in terms of my relationship with medications? So a bit of background on me, because it's important to the conversation that we're having. Even before I came into psychiatry training after finishing medical school, I actually did a psychopharmacology fellowship program. And then, of course, I entered a residency program and then another fellowship that was very biologically oriented. So when I came out of my training at the tender age of 31, I just knew there wasn't a problem in psychiatry that I could medicate. It just wasn't. I could medicate anything. And if patients didn't get better, it was either I hadn't used a high enough dose or it was the patient's fault. That was it. It was never a shortcoming of the medications. Of course, that has changed very significantly, but I think in a more fair, balanced way. I do think there are some disorders, some severities, that medication should play very little role, if any. And I'll use a couple of examples. Social anxiety disorder. I spent, 10 plus years of my life trying to develop medications for social anxiety disorder with very spotty success. until I truly encountered CBT and other behavioral interventions and obtained training in them. And then over time, I encountered other things such as wellness practices and many, many, many types of complementary interventions. And then I started really thinking, there are some disorders, I think I overdo the medications. So it's a very good question, but I hope you'll forgive me for not being able to give you a precise answer other than to say it's a dynamic process and we should not be afraid of the dynamism of the whole process.
Thank you for that, Rakesh. It feels very parallel and similar in some ways to my journey as a psychiatrist from training on. I was also 31 when I finished and started my practice. And I had a very profound case that happened. Actually, I'd like to tell you about it. I'm curious your thoughts about this. It was 2004. I had just finished my board certification. And I was actually very frustrated with in retrospect, I would call it treatment resistance that was stacking up in my private practice. And I had gotten involved with meditation and was taking some time off. And a patient who I had worked with for over a year doing weekly CBT and SSRI and PRN benzo, who had very severe social anxiety. And this is what triggered the memory, is your comment about social anxiety. We did mindfulness, we did CBT, SSRI, and a PRN benzodiazepine. And this is a person who was very limited, couldn't date, couldn't travel. He got about halfway better, maybe, with what I did with him. And then after I left to take time off, he went and saw a naturopathic doctor and was tested for celiac disease, came back positive, stopped eating wheat. And within a few months, his anxiety had ebbed away. And then he went off of his medication and he still had no anxiety. So it was an interesting experience for me as a young psychiatrist to be humbled that way about medical causes that I didn't know about. And it ignited a fire in me of looking at other alternative explanations for anxiety in particular, but also that led into, gut-brain connection and hormones and inflammation and some of these more complementary avenues.
What a wonderful case, Will. What a wonderful case. And I too have been humbled, and I'm as proud as you are to talk about my failures as I am to talk about my successes. Mm-hmm. And it is, I admire you for talking about, challenging cases and not just these great, wonderful successes that we hang as trophies on our walls, right? It has been humbling. But we should also acknowledge that there are as many people who don't have a particular problem, who make the erroneous assumption that they do. Now, let's just pick celiac disease, as you mentioned. For every one patient that I have detected with celiac disease, I have been able to rule it out in perhaps 99 people. Pendulum is an interesting thing. The beauty of pendulum is it doesn't just rest at the bottom of its path. It can go left and right. And I think those of us who do believe in the sheer raw power of complementary medicine in wellness would be well served by an extra dose of humbleness. And that humbleness is just because we believe that it is helpful for whatever percentage of patients and fellow human beings. It is not a good idea. Just the way psychiatry made that error, we will not make that error, hopefully, of assuming because it happened in my last 5 patients, the next 5 patients have exactly the same problem. I don't know if you agree with me on this, Will, or not.
Absolutely. I appreciate you bringing this forward. I think the way I tend to think about it is that there tends to be, in folks who embrace complementary and alternative approaches, a kind of I told you so kind of attitude. But I also see that in people in more conventional mindsets. So I think it boils down to what you said, is the word humble, and the kind of willingness to not know and to continue to be a student. As you said, ask you tomorrow, you'll have a different answer because you continue to grow, and that's how we all should be. I think in Atul Gawade's book about what it's like to be a doctor, and I'm trying to remember the name of the title. I think it was Being Mortal was the name of the book.
That's a wonderful book. Yes.
He mentions that a physician who doesn't know the answer is a worthless physician. And that really hit me between the eyes, because I think that we have such a fear of saying, I don't know. Let's keep looking. Let's keep our minds open to what could be going on here. I think we need that more of that, as you say, in every camp, right? And you could take this to a bigger political landscape as well, of how difficult it is for people who disagree to speak with each other anymore in this country. It's a big problem.
It is a big problem, and you articulated it really, really well. Every time we change our minds, it's almost always based on facts and experiences. And my favorite mind-changing moments are the ones when my false idols have been shattered. I love that. To kind of know that this was sort of wrong and it turns out to be wrong, that's not as good a learning experience. A better learning experience for me is to have these cherished beliefs about whatever the case might be, and then being shown the evidence that is so profound and so convincing that I not only changed my mind, by changing my mind, I've made my life better and the lives of people who are around me. Let's use mindfulness as an example, Will. So if you are listening to my accent, this is not an authentic Texas accent. I don't know if I've fooled you and fooled everybody listening to me. I may live in Texas, but I have lived here for 32 years. I'm originally from India. Now, many Westerners think India is the land of great mindfulness and great religions, and everybody is, meditating 14 hours a day. And that's simply not true. So I grew up in a place, in a time and an era where rejecting everything that was Eastern was automatically right. That's what I grew up in. Mm-hmm. And that's one of the reasons why I came to States. Because at that time, in the mid-'80s, States was very much into individualism, self-centrality, right? I found that very attractive until I got older. And I started facing my own challenges. And then, well into my early 40s, did I encounter meditation and mindfulness for the first time. And then I became, just like you, very encouraged by it. I actually went and got formal training by Zindel Segal, the gentleman who started the whole MBCT movement. We started an MBCT entire endeavor here. I practice meditation now on a near daily basis. And I am stunned, absolutely stunned by how wrong I was. And I love that. And I love that not because I enjoy being wrong so much, but there's more value sometimes to being challenged yourself. But if we can just pursue that conversation a little bit further, I also made another mistake of thinking of mindfulness as a psychological technique. It is not. It is such a strong combination of psychological, biological, and wellness. It's a 3-in-1. Mm-hmm. And therefore, these false dichotomies we sometimes draw between traditional medicine, complementary medicine, are to some degree not quite accurate. The placebo response to medications is real. And the biological
Absolutely.
response to physical exercise and socialization is real, right? So, yeah, I think we are all in need of loosening our own belief systems in a healthy way. And as you said earlier, talking to each other and listening to each other so we can all benefit.
Yeah, thanks, Rakesh. I think that's so aligned with how we teach in our institute. We're teaching an integrative model that's really about transcending and including. And I think that's challenging. It's very hard when there's so much polarization, like you were both talking about. And we're like, let's just get the best from all worlds. Why rule anything out, right? It's like we have so many tools now available to us, more tools than we've ever had on this planet. And we might as well get the best of all of them and know how to use them wisely and when to use them, what's appropriate. And I guess that brings me to the next inquiry here with you, which is, so for let's say either it's the therapist who's thinking of referring a patient to a psychiatrist for medication, or let's say it's a psychiatrist and all they're really used to is prescribing medication, but they're like, what else do I do? Do you have sort of a series of questions you're asking yourself to know if medication is a good fit for the type of thing that's in front, the type of person's presentation that's in front of you, or whether you would really encourage them to slow down in considering medication? Do you have kind of questions that you're wanting to get answered to work with that?
I do, and I suspect they're extremely aligned with how you folks approach your patients and your clients as well. There are some disorders where the case is closed. So if I have someone where I'm absolutely convinced this is their first break psychosis from schizophrenia, the case is closed. We're going for medications, and I will put all my emotional energies and all my persuasive powers in an appropriate fashion to convince the patient and their system, their family, that medications are central and needed immediately. But that's the easy one. Let's pick a completely different scenario where it is far more complicated: autism. In autism, it lives on such a spectrum, right? And an individual is not just on a spectrum, they are on a spectrum that changes month to month. So I've had scenarios where I've had to pursue completely opposite tracks, where you start with medications, you get things so much better for the individual and their family system, where medications are not only not needed anymore, they actually become an impediment to progress. And I'll give you a real life example of that in just a second or two. But there are other examples, and I'll give you a live example right now. I worked with a Baptist preacher from South Texas who had been sober from alcohol from, I think, about 30 years, between 25 and 30 years, and suffered from horrendous depression like, oh gosh, humans ought not to be facing. And yet he hadn't come to see me. He came to see me only because he could now simply no longer control his suicidal ideations. Just could not. He was convinced he was going to end up taking his own life. Even with him, because he was so opposed to medications, I was willing to wait 4 weeks because I had, in some ways, no choice. And I knew that he was not going to agree to it. And we tried CBT with him and other modalities. They simply failed. We gave him medications. And I got to tell you, 4 weeks later, he came back to see me. I talked to him every single day, but 4 weeks later, he came back to see me. And he did this. 30 years of suffering. And all I had to do was take this little yellow pill. And I followed him for 10 years. And then he moved on elsewhere, so I've lost touch with him. But by the same token, I'll give you a complete different example that only complicates the answer I'm giving you. I've had patients with panic disorder who I overtreated and kept them on their benzodiazepines and SSRIs. I now know longer than they needed, to the point that they can now no longer come off them without going back into profound panic attacks. So what questions am I asking? This is what I'm asking them and myself. What is the disorder? What is the severity? What is the family history? What are the patient's preferences? Preferences really, of course, matter. And then finally, pragmatically, where am I willing to concede to the patient's wishes and where I simply won't? If the situation absolutely demands no medications, a patient has a recent challenge because of addictions and they're asking for the Xanax again, I'll hold the line and say no, and vice versa. But other than that, it's a complex set of issues I interact with before I pull the trigger on medications. Does that answer your question to some degree?
Yeah, it answers my question. And I think another way we could kind of now go down this rabbit hole, and different sort of rabbit holes, would be, let's talk about depression. Depression, just looking at the trajectory of people with clinical significant depression over the last number of decades and where we're headed, it kind of feels like in 50 years from now, more than half the world's going to be depressed, potentially. I mean, there's a lot of depression. And of course, we see a lot of treatment-resistant depression, where medications are failing. And I'm curious for you, when we kind of drill into depression, how do you think about medicating people who are on the spectrum of depression? Obviously, we have all the way over to one spectrum of like the full-blown psychotic depression. And then we have, more of like intermittent depressions and things like that. So I'm just curious, how are you even framing now the conversation for yourself around medication with depression?
So besides being an MD, I also have a master's degree in public health. And the reason why I bring that up is because I obtained my master's in public health in 1987, where the American risk of having depression was about 8.7%. And today, in 2020, the risk is now closer to 21% than it is to 20%. What the heck happened to us? We got wealthier every single year. Our life expectancy went up. We launched 25 plus psychiatric medications, including 10 antidepressants. And this is what we have to show. So even though you were kind enough not to point it out, I am going to point it out. With most psychiatric disorders, psychiatry has been a dismal failure, actually. We've not been good. Traditional psychiatry has fought valiantly. It's not that we're lazy, but it's not worked out. I think, and now I'm coming back to answer your question, it may well be because we took too much of a biological angle to treating it. And when I say biological, I mean medication biological. There are many other biological interventions. That includes meditation. I actually think meditation is a biologic, psychologic, spiritual intervention. We did do that. And as a result, not only do we suffer, look, I also get to interact a lot with my colleagues from all over the world. I just did a training seminar for my physician colleagues in Thailand, where they're reporting an explosion of major depression because they have adopted our models. When I say our, I really do mean the American. I don't mean the Western world. I do think American psychiatry is probably more imbalanced, infatuated with pharmacology than perhaps any other country I know of. As a result, the approach that you folks have taken at your institute is actually a very good one, which is a holistic approach, a curative approach rather than a symptom control approach. I resonate with that very loudly. And of course, the time horizons for recovery should be a lifetime, meaning you do not kind of, call it a 3-month episode and then kind of say, you're in remission, I'm done with my job, I'm out of here, you don't need me anymore. But a true lifelong approach to curing it. But let me also, if you will permit me, I do want to maybe not disagree with you, but just point out, just because it's mild truly does not mean that it is not going to be exquisitely and positively sensitive to medications. Some of my most chronically ill, low-grade depressed patients actually have done so well with psychopharmacology despite 10 years of every known diet and every known vegan diet and gluten-sparing diet and high-dose IV vitamin B6s and oxygen therapy and, all kinds of wonderful things that really do work for people. But for them, if $4 for a 30-day prescription medication evaporates their depression. So there we go. So see how challenging this is it not?
I'm really enjoying getting a peek into the complexity of your thinking process, Rakesh, and your willingness to hold the union of opposites really in our thinking. And it reminds me of when I was a medical student and picking a career, which specialty should you go into? And they gave us a questionnaire, and one of the questions was, how comfortable are you with uncertainty? And if you said very, then they put you in psychiatry. If you are not very comfortable, they recommend you go into surgery or something different, I guess. But there are two pieces here I want to further explore with you. So the first one I want to bookmark, which is, I think, a big part of what we're talking about today, is the appropriate use of medications at the right dose and for the right length of time. So I want to come back to that. But because you mentioned coming out of your background growing up in India and kind of the prevailing environment of rejecting Eastern perspectives, and your encounter with American society and this focus on the self, I'm very curious. I've been reading Carl Jung recently, and this concept of the ego being healthy when it's in connection with this bigger capital S self or this divine self. Do you, in your movement, growing older and maybe being less connected in with a young man's point of view about the self, do you feel that there's something about American culture that needs, I guess what's coming up for me is this sense that we have that the ego is the crown or the sort of pinnacle of Western development, let's say, for a human being. But it seems like a recipe for depression for us to sort of crown the ego as, okay, I've got a functional ego and therefore I should be happy or I should be fulfilled. It seems like there's something more that people need. What's your view about this relationship, about the self?
You and I are brothers from different mothers, is what I say. Despite our backgrounds, we are very unified. I totally agree with you. My mood and my wellness is incredibly influenced, whether I know, by my nodes of connection. So, Will, I know you now, right? I know you, Keith. Therefore, your mood, positive or negative, affects me. We actually know how much it affects me. We know that from the Framingham Heart Study, where they look not just at the heart markers, but actually wellness and disease transmission from people to people who are not genetically related. So, Will, I really hope you are doing well, because if you are, 9% of your wellness will actually rub off on me. Now, here's the interesting thing. Your friend, who I've never met before, ever, that person's happiness or sadness has a 5% effect on my sadness or my wellness.
Wow.
And by the way, that's 2 nodes. The third node, meaning that friend whose friend you have never met before either, that also indirectly affects me. And this flows both ways. So to support your point, I do think as human beings, there's societal wellness, which we have just abdicated. It became, you're so right. I came to America because I found everything American to be. And I still do. I love this country. I'm here by choice. I just think it's such a fantastic country. But there are so many things we do well, but there are a few things we don't do well. We did abdicate this very large part of who we are, our psyche, our soul, and our brain. Our brain, like right now, when I'm looking at you, I am spending a shocking amount of energy looking at your face. But that's not me. That's what my brain is. I am designed to read your face. I am. I'm designed to read every expression you've got, even micro expressions, good, bad, neutral, whatever the case is. I'm a social creature. Whether I want to be or not, I am. We did abdicate that. But the other thing we abdicated was genuine spirituality, not religion, which is, of course, a different thing. And I've only discovered in the last couple of decades, and at least for me, that journey was heavily influenced by my psychedelic use. That really has influenced my growth. You talked about Jungian philosophy. I read it because I was required to read it. Because I'm a psychiatrist, you have to read all that and be able to pass exams. But I didn't quite understand when he talked about the connection with nature and connection with the self greater than you, what it means. And when that is well developed, what a positive influence that has on you for a long time. I hear you. And I am resonating loudly with you that recovery from depression, the small d depression, which I do think is different from the big D depression, does require going back to our ancient selves, because our ancient selves had a set of skills that we let go of once we landed in this industrialized nation model. And no country does industrialized nation better or worse than we do here in the United States.
Yeah, I mean, I totally agree with you that this is the 2 sides of the coin of the beauty of the American system and the tragedy at the same time. And I'd like to come back to this issue of how long and how high of the dose. And our mutual friend Chuck Raison mentioned recently that you had an interest. I think he said that you had a familiarity and interest in this concept that's become a part of the conversation recently in psychiatry about the risk of tardive dysphoria. Mm. And when you spoke recently, just a few minutes ago, about your patient with panic attacks, and I wondered if you were alluding to the person who has a hard time coming off the SSRI, and how does that factor into changes that you've made over the years in your prescribing habits? Yeah,
maybe we should define tardive dysphoria for our listeners, because it's still, even though it's being talked about now for 15 years, it's still a relatively nascent concept in our field, isn't it? So dysphoria, of course, is sadness. Tardive would be late arriving. And the concept is really very much like tardive dyskinesia, which is you often get the opposite of what you are seeking, an opposite of what you originally got, just by staying on intervention for a long time. And there's a lot of parallels with multiple other fields. Example, oncology. In oncology, if you treat a child who's 10 years old for acute leukemia, good for you, because you now have a 95% chance of helping that child out. But without meaning to, you really have increased the risk of them developing a leukemia type disorder in their 50s and 60s. Just because you had to apply that treatment to save the person's life. So this concept of tardive rearrival, later rearrival of the disorder is actually not new to medicine. We have seen that for a long, long time with multiple disorders, including obviously tardive dyskinesia. Tardive dysphoria is a very interesting and a pretty worrisome potential complication of long-term antidepressant therapy. Clearly not in the majority of people. It is important we not end up scaring any lay or professional audience members. But we also need to advise them that this is a concept that may become of some importance, where just because you've been on antidepressants for a while, your brain, I mean, I say brain, I think I should perhaps narrow it down a bit. The neurons and the receptors that really are the currency, really the tools that the brain uses to communicate with each other, may configure themselves in such a way that not only do you no longer respond to antidepressants, you may be depressed because of the antidepressants. You might as well go ahead and challenge me now. What is the biologic evidence? Show me hard evidence. And I don't have it. It does not yet exist. There are, however, sadly, a lot of tantalizing clues and worries that maybe in 10 to 15% of people, tardive dysphoria can occur. So what do we do with it, right? So this may be a good time to rethink and be more cautious about who to offer medications to, who to perhaps gently push towards looking in other directions, at least for the time being, and then who should continue beyond a certain length of time, be it 6 months, be it a year, to potentially decrease the risk of tardive dysphoria, while at the same time making sure a patient who does need long-term treatment isn't denied what potentially could be a life-saving treatment.
Again, we're very aligned here, Rakesh, and I think it's, I just want to reiterate the point that you made that when medication works for a person, it can be absolutely life-saving and essential and necessary for in the long term for some people. And we certainly don't want to discourage anyone who needs that or cause them to even doubt or feel second thoughts or for sure any sense of shame of needing that ongoing support. Everyone needs ongoing supports of a wide variety of different flavors and forms. What we're talking about is this concern that in a minority of people, there may be long-term consequences that we previously didn't understand well enough and still don't understand adequately to make sweeping recommendations. But we do want people to be aware about these emerging, it's sort of like a figure coming forward out of the fog of ignorance and through the shining the light of experience onto this figure coming forward that appears to be something like crossing a threshold where now the depression in this case may actually be more of a result of the treatment as opposed to the treatment being the curative effect of the condition in the first place. It's
which is why yeah.
Yes.
Will you forgive me for stepping on your words there?
Not at all, please.
Okay. Which is why, Will, we should come to a few agreements. The agreement is, I don't know anybody who suffers from any psychiatric condition who would not benefit from more than biological interventions, right? So why don't we, while there are so many unknowns in the field and there are complexities in the field, there's one thing we can agree to, not based on our belief system, but based on our belief system and the evidence at hand. No one, whether they're psychotically depressed or quote unquote mildly depressed, should avoid taking full advantage of the full array of complementary, holistic, and wellness techniques. We agree.
Right.
And by doing so, you're decreasing your dependence on any one modality of treatment, which is, it's like investment. Would you invest everything in just one single stock? It's a highly risky maneuver. You might really succeed, but what if that fails you? Then it's a problem. So we do agree on some things. But look, if you get a fracture of your leg, the orthopedist will put a cast on you. And that's a good thing. But the orthopedist is going to be very quick to take it off the moment it is safe to do so. Why? Why not just leave it on for another 6 months? What's the big deal? And the reason for that is leaving a cast on when you don't need it actually weakens the very cause that you're trying to fix. The very bone you're trying to heal, you have now made weaker by doing something longer than you needed to. With depression, just like the bone in my femur, maybe 3 months, but in my hand, maybe 6 weeks. Well, why can't depression also be the same thing, variable in terms of needs? What do you say to that, Will?
1,000% agreement. That's all I can say. Absolutely. In fact, it's funny because talk about brother from another mother. I use the very same analogy of the orthopedist and the cast in my clinic with my patients. So
it's a great analogy, isn't it? Good. Yeah, I did not know you did that. But the very fact that a specialty as different from psychiatry as orthopedics has in its own way, and they'd probably learned it 200 years ago, because they had casts back then, Will. We only got our casts. Psychopharmacology was born in 1952. So we are a very young specialty. We're just learning. But as we're learning, I'm so glad in your podcast, you're highlighting that there is not a one direction response to our interventions. But there are some things that really do have one direction. I have never, ever heard someone being directly harmed because they led a well-balanced lifestyle. I just never have. Never. You would have thought this man is 58 years old. Maybe he's by now at least met somebody who was harmed by doing that. So maybe there are some unifying principles in life that are true for everybody. So we live with the certainties, which is very good, which, by the way, are solid and ancient and wonderful. And these uncertainties, we will navigate that with consultation with our patients, but also with a very open mind and a heart.
Right. And it brings up this, I think, dynamic that we haven't named yet, but it's so clear and so present here, which is accounting for the risks when we inform our patients about the choice of whether to do a lifestyle intervention or a medication. And I think that I remember reading that back in the 1800s, there was a big schism between naturopathic doctors and physicians around the treatment. I think it was a treatment for malaria, if I remember right, where we as the MDs were giving people mercury, intravenous mercury. And more than half of the people died, but the ones who didn't die they were cured. But the naturopaths had a much less toxic treatment where way more people died from the original disease, but basically no one died from the intervention. And so patients were getting in line for the naturopaths because at any rate, they didn't want to be killed by the treatment. They would rather die from the disease than the treatment. And so there was this movement that happened to sort of dominate the medicine, where the AMA, I'm don't have all the details at the front of my mind, but we came in with these more risky and more dangerous, let's say, treatments that provided more benefit for the people who got benefit, but there were more risks of harm. And I think part of the popularity of alternative medicine and complementary techniques is along these lines, is that a person faces less efficacy in many cases, or very weak evidence for the treatment in CAM versus, say, a double-blind placebo, phase 3 FDA data for medication. But there's a perception that you're going to also get less side effects, or you have fewer negative experiences from CAM. And so there's this interesting balance that I think as practitioners we have to hold of first do no harm, but also do enough to actually impact the person, right? So that's how I feel about it. That's how I think about it.
You are wiser than your years. You really are. Yeah, that's exactly it. That constant tension between, is it enough? What is the price for it? Is it not enough? And what is the price tag to that is one that we constantly have to hold in our heads. And it's not easy. It's just not an easy decision for us. But imagine how difficult it is for patients. They actually have to live with the consequences of their decisions. How interesting you brought up the 18th century experience. I read a book that was incredibly illuminating called Lincoln's Melancholy. If you ever get a chance and you are free during this pandemic to spend a couple of days reading a great book about American psychiatry, read Lincoln's Melancholy. He attempted suicide 4 times in his life. A very serious suicide attempts. I believe the first or second one was at 19, and he got treated by the leading psychiatrist of that time, Rush. And the treatment was lead and mercury and arsenic and a few other things. Well, Lincoln got horribly, horribly sick from it. And I think he got sick enough that by the 6th day, he said, I'm cured. Leave me alone. I'm leaving treatment. Which was, but it may have, wow. But also, let's go back to that. But look what else. So they did for people who had depression that we don't do now. We don't do as well. They used a biopsychosocial model. They really did. They really do. They use what we call alternative today. They call essential. That's why I have such a problem with calling it complementary or alternative. And because complementary means it complements something that is essential. And it's the other way around. It's not complementary. It's essential. It's baseline. It's foundational to being a human being. And why do we call it alternative? Because alternative means, oh, you didn't find that on Amazon Prime? Here's an alternative. It's about equal to the same thing. And that's simply not true. All the things we talked about, you talked about mindfulness, but if we go further, if we talk about homeopathy, for example, if we talk about wellness interventions, for example, even sleep hygiene, social activity enhancement in a focused way, all of these other things, those are not complementary. Those are not alternatives. Those are the foundational things. So I do think if Western medicine, which I actually believe has great power, and I'll defend it. And I'll defend it because I do believe it has a major, major role. But if we started thinking of it as an add-on and not the centrality of the intervention, as an intervention to offer when other things aren't enough, oh my gosh, I think we'll not only end up harming fewer people, we probably will end up helping more people, both in the short and the long run.
Yeah, I think we might have our terms flipped in terms of what's complementary and alternative to sustaining life and thriving. This kind of, I want to share a short personal kind of anecdote here, which is psychiatric medications have been very essential to my own healing process. So I recommend psychiatric medication still to people regularly in certain cases. And as long as I've been on psychiatric medications, I've had to wean off almost the same amount of time. We're talking like, 6, 7, 8 years on, 6, 7, 8 years weaning off. So what I've discovered, and I'm one person, and I hold that when I talk about these things, but there's this whole concept of, are you having symptom recurrence when you're coming off your medications? And with some medications, there's a very direct conversation about rebound when there's, the capacity to build a fast tolerance like benzodiazepines and things. But I've seen not only myself, but a lot of people I've worked with where I think it's very hard to tell the difference between a true symptoms reoccurrence versus having rebounds on medications that we don't normally talk about as having rebound. And I've tried medications in almost all the classes, and I've seen, I believe, rebound in all of the classes. Where you would use, let's say, antipsychotic for sleep that you wouldn't assume would have the same type of rebound as a benzodiazepine, but then you stop and you can't sleep for 3 nights at all. And so to me, this brings up the conversation of, if it's so hard to get off of these medicines for some people because of having a pendulation in the brain of some sort, well, now what do we do? How do we talk about this with people? 10 years ago, no psychiatrist ever once mentioned anything about this to me, ever. It was just like, no, these meds, there's no rebound here. There's nothing. Like, if you're coming off of these and you have new symptoms, like, you're having a reoccurrence of your issue. So I'm just curious about your thoughts on this. And
yeah. So remember, we were trying to find some very common grounds that apply to everybody. So here's one more very common ground we can apply to you, Keith, to me, to Will, to everybody who's listening, and every patient who's ever taken a psychiatric medication. Take this to the bank, what I'm about to say. Every medication has a rebound. Addiction is not the same thing as rebound. Lithium has one of the strongest rebounds known to mankind, has no addiction potential. And it is biological reasons for it. And I see that you wear glasses. I don't wear them now only because I had LASIK eye surgery. But you know what's interesting? If I had my glasses on all day and I take them off, my vision was bad. But it was worse because I had my glasses on all day than it typically is if I don't have them on for 4 or 5 hours. And that's a rebound. That's rebound vision. Neurons rebound no matter what the medication is when you remove it abruptly. And abruptly is in psychiatry defined very differently, Keith. We have sadly mistaken half-life of the medication for the rebound duration. I have now seen benzodiazepine withdrawal last 2 years. I have seen SSRI, which is quote unquote not addicting, rebound last 6 months to a year. I've seen lithium rebounds that you can still hear the reverberations of it 3 to 6 months after you stop taking it. So psychiatry did not know about it. But now, and I'm leading this, I'll take credit for it. I mean, it's okay to take credit for it when it's appropriate. So I'll take credit for it. I, this year, conducted the first deprescribing seminar for psychiatrists, to the best of my knowledge, ever conducted. And the reason why I did it is because what you're just describing is true. And prescribers are simply unaware of it. And it's very difficult to caution a patient about something that you don't even know is an issue. Now, am I so smart to have figured it out? Heck no. The only reason why I am completely cognizant of the challenges with withdrawal and rebound. Let's call them slightly different things because they are, but they're both very challenging. It's because it took about 20 years of hundreds of patients telling me, you are missing the boat, man. You are just not being accurate. So I went in, I looked at the literature, we conducted some of our own research, and we went, yes, individuals are suffering because the human brain just doesn't like sudden changes. So what am I now with my practice with it? Same place where I was. If I do start a medication, I want to be cautious in terms of, is it right? If it is right, the least effective dose, the fewest. But I have several patients who are on 9 or 12 psychiatric drugs. Call me a bad psychiatrist if you want to. But that's not, I don't believe that is the situation. They simply need it. But each one of them, I'm cautioning them, every medication we have can have a rebound. It's a potential challenge. Please know I'll walk the walk with you. We will do it carefully and safely. Did I answer your question? I'm very much hoping your own psychiatry team in time becomes aware of, maybe because of our conversation today, maybe because of some of the writings that exist in the field, that deprescribing is probably as important as prescribing and actually requires a greater set of skills than just prescribing a medication.
Yeah, I mean, yes, you definitely answered my question. And well, I would agree as a patient on in psychiatry that deprescribing skills seem to be much more complex than prescribing skills, because you have to be very patient as a provider with it, very, very patient.
Yes.
Whereas prescribing, the ramp up is much quicker.
You said it beautifully. And prescribing, there's some heterogeneity. Like I may start someone on 5 of Prozac, someone on 20, but ultimately I'm sort of going someplace. But deprescribing, oh my goodness, you create a route for that particular individual, and you should be, I'm talking to me, the prescriber, you should be willing to change your route. And Keith, just yesterday, I and my research partner recorded a presentation. Now, this, I got to tell you, this is going to be torture for whoever listens to us. A 6-hour psychotherapy presentation. Thank God, broken into 3 components. It's a update on psychopharmacology for the non-prescribers that we will show at a pretty large biannual meeting called Evolution. But I spend a lot of time talking to non-prescribers about the importance of learning about deprescribing, because deprescribing isn't just the prescriber and the patient. It is the prescriber, the patient, the therapist, and the family. We all have to collaborate to help them come off it with minimum and hopefully 0 challenges.
Yeah, thank you for your contribution there, and also for paying attention, over the course of your career to recognize and challenge what you were told, so that you can dig deeper to find out some answers. And I am aware of the time, so we could talk for a long time. This is really fun, but so I want to wrap up here with you. So we end with the same question to every guest. And the question is, if you had a billboard that had a paragraph on it that every human would see once in their lifetime, what's the one thing you would want them to know?
I've never been asked that question, and I love it. Oh my God. Okay, sure. I am more than happy to tell you what I have learned in 58 years of living in 2 continents, but more importantly, living in 2 continents up here. It has been remarkable to live in 2 very different continents, of thinking just one way and then being able to change it. Perhaps what I would say to people is this. instead of asking yourself what's wrong with yourself, you might as well ask yourself what's right with yourself. Most of us are very blessed to have more right with ourselves than what is wrong with us. Appreciate that your brain will often lead you astray by perhaps making you ruminate and worry. But if you focus as much on wellness and being a holistic individual with a well-developed spiritual life, a well-developed social life, and a well-developed life filled with purpose, that's a well-lived life. And should the slings and arrows arrive, don't avoid seeking professional help of any kind. It is not only okay, you are honoring your mind and your body and spirit by seeking the help so you can be back on your track to asking yourself every day, what is right with me?
Thank you. Well, thanks so much for being on the show, Rakesh.
Thank you both for doing this. You don't have to do this, but you're doing this out of caring for your colleagues and your patients. And I admire that. I really do. So well done, gentlemen, and keep at it, okay?